it's probably going to take a little bit of time to get that worked out. Today, we'd like to welcome back Professor Luis Angel. As most of you know, he's the medical director of our lung transplant program and the director of the interventional pulmonary program, I guess, is the best way to say it. Luis, when did you join the program? About 10 years ago?
2001.
Oh, 2001. Oh, we came about the same time. And he became professor. I'm still stuck at associate. So I'll tell you the difference there. Today he's going to talk about personalized transplant medicine. Yeah, I know. We won't get into it. And OMICs.
All right, thank you for the nice introduction. It's happened to talk about this area that we really don't know much about, this personalized medicine and what OMICs stand for. When you look at this, it's something that is coming more and more, and it relates to some of the areas that we are, again, and many people is doing research that is looking into the genome, or it's genomics, transgenomics, proteomics, metabolomics. So it's a lot of different things that are kind of progressing on medicine right now. And what I'm going to try to show is why is this important in the future of what we do in transplantation. So this is a picture here. This is in the Antarctic. And this obviously, as you see here, 3 little penguins and they are seeing this big boat coming in here. And this is from the National Geographic that is just coming to explore and learn all of this. It's obviously with millions of dollars of equipment. And they are just kind of looking into this and see what is coming into us here. And truly, this is the way I see omics. This is a huge thing that we don't realize now what it is, but this is huge. And it's going to completely change the way that we practice medicine today. So to look into the future, I think that we need to go first into the past. And this is during World War I. It's called the cycle ambulance. Also, it's one of my passions is cycling, and the Oregon is medicine. But you look into this is 100 years ago. Look at this picture. And they are transporting here a wounded soldier. And you have to imagine what were the chances 100 years ago that somebody was going to survive any kind of wound that they were having in a war. So you just kind of fast forward 100 years, and this is where we are now here. So first of all, this is an airplane where we have here. Secondly, you look carefully, there is a pacing here. So the head is there, and this is the footing here. And this is an incredible amount of equipment that you have here. This is a ventilator. This is an ECMO circuit, all kind of chest tubes and monitors. And if you look into the detail, there is even some hands in here. This is a nurse, critical care nurse behind all of this, taking care of this patient during transportation. So there is no question in my mind that there is no better time in history to be a patient and to be taken care of than what we are right now. Again, the progress has been incredible. And this is very exciting what we are doing, but is this the most exciting time of medicine, or do we need to move into something else? To look into that, again, all of this progress has not been just related on seeing exciting things and incredible new machines and technologies. I'm sorry, just let me move back here. Has been also translated in a significant improvement in the life expectancy in the United States. So when we look at the picture of 100 years ago, somebody my age, again, if I was 100 years ago, 50% of the people that was born around my age will be dead. Where we are standing now here today, if you are a female and 80 years old, 50% of the people will be dead, and 50% that were born at the same year still are alive. This is huge. I think that this is one of the most incredible progress that you have seen, and it's not just because of medicine. But I think that people have to recognize that most of this progress has been due to advances that we have on medicine. So when you look at the New England Journal of Medicine.
Thanks for putting that slide up for all of us to see our endpoint.
Yeah. Yeah.
Greg and I were saying we got 20 years left.
Correct. Excellent. So this is again, the New England Journal of Medicine was celebrating 200 years of again, this is the main medicine journal that we have. And when they asked them, just pick the most relevant article that you have in these 200 years, they pick up this article here. And let me kind of explain a little bit what it is. But it's not just the fact of what happened. It's what the essence of medicine is, and hopefully will be also again in the future. So this is at the Mass General Hospital. This is a room here that is still, if you go to Boston and for some reason you are curious and you want to go into this room, you can go at the Mass General Hospital, and it's called the ether room. And you see that distribution, again, is just this area here. This is a circle that goes around this area, and it was almost like a circus. People can go there and they see these incredible things that were happening on medicine. And in 1946, this is why the New England Journal felt that was the most important thing that they have ever published. And it's this, a lot of people here, but these three guys who are the most important ones. So obviously, the most important here is the patient, that we still feel that is the most important person in the whole area of medicine is the patient. So this is Edward Abbott, and he presented to the hospital with a mass here on the mandibular area. There is a doctor here who is the surgeon, that is Dr. Abbott, that is doing the operation. But the thing that was very incredible is here, there is this doctor in here, that his name is William Morton, and he's a dentist. And what he is doing is he is giving ether to the patient here for anesthesia. So they start giving the anesthesia, inhale anesthesia. Everybody is looking here, and when they do a description of this picture, they say that the mistake here is that everybody was jumping and they couldn't believe what they were seeing because they were able to do this operation. And at the end of the operation, Dr. Warren finished the surgery and Abbott regains consciousness. The surgeon turns to his medical audience and he said, "Gentlemen, this is not a humbug." Truly, I didn't know what the word means, being Colombian and English being the second language. But he said basically it's acting as deceptive or false talk or behavior. So he said this is real. But to me, what is exciting is looking the fascination that medicine was about that time. It's so incredible how people was fascinated and drawn to medicine and see how these things were happening. Unfortunately, that progress was moving extremely slow. These are my grandparents in Medellin, Colombia, and this is in 1948 or 46. This time he was 62 years old. He couldn't urinate very well and he needed to have a prostate surgery. Routine, nowadays, people go for this kind of operations. They didn't go for transplantation like nothing. But he was going to the hospital for a prostate surgery. And look what he has to do. He has to do the day before, he has to write a letter. And the letter that he's writing, he's saying, Caldas, this is a small town where he was, September 23, 1946. Amirita, that is also my grandma, and children. This is my father in here. Before leaving for the hospital, my last provisions that must be fulfilled. He's just going to the hospital 100 years later, after the first anesthesia. Going for anesthesia was, again, chances of you dying at that time were incredible. So he has his prostate surgery, and unfortunately, he didn't wake up. We lost him 100 years after the first anesthesia. Still going for anesthesia with ether was incredibly risky, and we lost him there. So then my father goes into medical school around that time, and really, pretty much what you need to know about medical school was in this book, was Principles of Internal Medicine of Harrison's. Everything was the Bible on medicine, everything that you need to know, even when I went into medical school. You have Harrison's, and if you knew Harrison's, you were a really big internist, and you knew pretty much everything. So it was pretty significant, and what I'm gonna try to go here is go over the next 50 years of medicine and see what kind of medicine he got to see. Because I think that has been probably the most exciting time on medicine that we have. So let's look over surgery. What kind of things happened on that period of time? Obviously, this is transplantation and the kidney transplant, the first kidney transplant, It happened in the late 50s. We start replacing hips. And then this incredible thing happened. We have the open heart surgeries, bypass, and then liver and heart transplantation. When I was probably around 12 or 13 years old, again, as kids, we obviously have our friends and the mom of our friends. And my mom would just take us all to the airport. And he say, hey, we have to go to the airport because Alba Chavarria, her best friend, is going to Houston because she has coronary artery disease and she's gonna die. This is again in the early 70s when you have coronary artery disease in Colombia. At that point, there was nothing to do, and people usually drop dead because they have a heart attack. And they say, oh no, we are going to Houston. And when we're going to Houston, it's because there was something incredible happening here. You have this doctor here, Dr. Cooley and DeBakey, and many others doing surgeries in Houston for the heart. And this was exciting, like again, like that picture that I showed you from 1848 at the New England Journal. This was extremely exciting for everybody in the US. These two guys were doing surgery like crazy. He came here actually when Dr. Cigarro was the president of the school. He came here and he gave the presidential lecture, and he showed the OR schedule for a single day. In his OR, he has 26 open heart surgeries. There is nobody doing that kind of surgeries right now at that rate. It was really, really incredible. And even Life magazine was saying, this is so exciting. These doctors are incredible, the things that they are doing. Time magazine, the same thing. Christian Barnard, 1967. They are doing heart transplants. It was really incredible, the things that were happening in surgery at that time. Then again, we keep progressing, and on the 80s, laparoscopic surgery come. We can do these surgeries for the eyes, and more recently, we can do robotic surgery. It's not depressing for surgery, but I have to say that the major things that we can do with our hands in surgery, probably we already are over those. It's not like it's gonna be a brand new surgery that is gonna come and is gonna revolutionize medicine. I think that that period of medicine, like I was showing with my father here, he went through all of these periods, and this is incredible and exciting. But I don't think that it's a new surgery was going to be the change of what we're going to be practicing in the future. What about what we do in the ICUs? It's up to 1940 that there was absolutely no data that for you going into a hospital was better than staying home. If you go to a hospital or stay home, there wasn't any difference. There was no benefit to be into the hospitals. But then if you go again 15 or 20 years later, we start having these high complexity places, and we have the dialysis unit and mechanical ventilation that are open the ICUs. Then we have this catheter, and this catheter was one of the most incredible things for me as a medical student, and probably the reason I ended up doing critical care. It's just, we were in our hospital there, was probably not the regular practice that we do here in the US, but we have one Swan-Ganz catheter that was used probably 20 times. You just go use it, reuse it, reuse. But the excitement every time that you place one of those catheters was incredible. Measuring all of these things, and again, this is Dr. Swan and Ganz when they invented this thing. Then it comes the angioplasty, and it comes the stents. The stents also was a huge revolution. We are also, again, proud and sad to say at the same time, Dr. Palmas was the inventor of the stent here at the University of Texas Health Science Center in San Antonio. But we didn't have the good vision here at the school to recognize that this was a great idea, and we just cannot release it and say, oh, this is probably not that good. But it was very good, and really revolutionized medicine. Yes. Yeah. But it was something extremely incredible. Somebody, again, this is around the time when I get here as a student in 1991, came here as a student, and it was incredible. These patients arriving into the ICUs with chest pain, myocardial infarctions. They go down to the cath lab, and they come with these stents, and they are, again, fixed in terms of that coronary artery disease. So very, very incredible things. And now, again, we are doing some ECMO and ventricular assist device, something. But again, there was this period of time when we have all of these huge improvements that make the biggest difference on critical care. What about radiology? Again, for years and years, all we have is just regular x-rays, and this has been incredible. We have, again, in the early 50s, we have the ultrasound, and then you have the CT scan. This again, probably these people here that is old enough to remember this, but the first time that you see images of the brain on a CT scan, that is the initial CT scan, this was incredible. When we were able to see this and diagnose a lot of things with CT scanners, the MRIs, and if you look into that, basically, again, since this time, all we are doing is making a lot of progress in quality of the images, but the technologies are pretty much the same. And then the next area, obviously, the one that is more related to improvement on this life expectancy, I think that has to be the medicines. And it was also obviously an incredible period. This is probably two of the most important medicines in the history of medicine, the insulin and penicillin, and then the vaccinations came up. So this was very incredible. Then I'm going to go very quickly over many medications that they come over different periods of time. And I started here, for example, the cyclosporine in the late 70s, early 80s that allowed us to do transplantation. Then they come these three green medications from here, the PPIs, Lipitor, and the SSRIs. Those are what we call the blockbuster medications. These medications came on the 80s, and they are still the blockbuster medications. So things that came a long time ago, and are those medications that they sell into billions of dollars every year. HIV medications, which was incredible. When I started my fellowship here at the ICU, we have always 4 or 5 patients with advanced AIDS, PCP. These patients were dying all the time, and in a few years, they were able to come up really with medications for treating of this to become a chronic disease. And these are some of the most recent medications that are becoming really important, but as you see, again, the bulk of the medications that we use today, again, that was things that came in the 70s, 80s, and in the 90s. And if you look here into the most important drugs, and the list here probably is a little bit hard for you to read, but it's exactly the medications that came in that period of time are still the main medications today. And if you look into the FDA drug development, again, the peak was in the 90s when we were developing most of the medications, and this is decreasing, and all we have is an incremental change on something, but it's not like a new class of medications for the most part. So in becoming a doctor, again, in the last 100 years, I think that this period of time was extremely significant. And what I will feel that this, or at least feels to me, is like it was this huge peak. Luckily, I think that I was during this big part here in practice, but this is where I feel that we are right now. We are in some way in some kind of decline. It's not like we cannot provide the best care. We can provide better care now than we have ever done. But I think in that big innovation, that big thing that we were seeing over those last 50 years, in the last 10 to 15 years, it's just very little that is coming that is kind of creating that big impact and big change in our patients. So the question is, what is going to be coming next for this next generation that is going to keep them having the excitement that he has, the excitement that I have during this period of time? What is going to be next? That is going to be extremely exciting for the patients and for the future physicians if one of them become a doctor, that is going to be attractive to them. So this question was asked to 2 people that really they have a say so on this. And one is obviously the director of the National Institute of Health, and the reason is because he has billions of dollars that he's giving for research. And he's going to giving the money to the things that he thinks are the future of medicine. And the other is the editorial board of the New England Journal, because they publish and they have seen during 200 years the most important things in medicine. And they ask, what do you think that the future of medicine is? So in the Wall Street Journal, they have this special article when Dr. Francis Collins, he basically say, I think that the future of medicine, what is going to be exciting is going to be this personalized medicine. And personalized medicine is trying to change what we do, this one size fits all, and that's what we do. Every transplant patient that gets here, we almost can stamp, everybody start with the same medications. And he said that that is going to be really outdated, and in the future, we're going to look into this and say, oh my God, this is like the all medicine, where everybody was getting the same thing when they are right here. By chance, again, it's not like the 2 look what they were saying in the New England Journal, they write the same thing. It's going to be the individual person. That's what's going to be coming, that's going to be important in the future. And it's going to be this precision medicine that is using all of this large population database and looking into all of these omics. So this is what they are talking about. Personalized medicine relates to these omics, that is epigenomics, transcriptomics, proteomics, and metabolomics. Unfortunately, again, to understand all of this is the kind of journals that you have to read, Nature. And that's obviously, for my mind, is extremely complicated, so I can read Time magazine. And that one can explain you a little bit more what it is. It's really, we want to know the future of the patient. When they come here for a procedure, we want to know what are the chances of theirs. So for transplantation, this is what I want to know. What is my future with the lung transplant? What are the chances of having rejection, cancer, BOS, developing renal failure, opportunistic infections? That's what we would like to know on these patients. So omics also, they have a history. It's not like it's something new that is just coming up right now. This is, again, Francis Crick and James Watson. Again, Watson and Crick, the guys who described the DNA. And this is a beautiful story, too. Again, we know about the chromosomes and DNA from many, many years ago, almost 100 years ago. But just being smart and being lucky, too, and being at the right place. Again, Dr. Francis Crick was in a presentation, and he saw actually, and this is one of the big debates in history of the DNA. There is a female doctor from England that she took a picture, and it's called X-ray crystallography, of what she thought that was the DNA. And she took the picture, and he was in that presentation, and when he saw the picture, he kind of understood and said, okay, I know what she's seeing. But I understand, but this is a double helix picture. And they went and actually described the molecular aspects of the DNA, and then it comes to what scientifically has been the most important article on medicine. Again, historically, I think that the New England selected that one, but to me, this is the most important article, again, in terms of the future of medicine, and was when Dr. Watson and Crick described the molecular structure of the DNA. What a different medicine was there. Look at this. This is a one-page article. You will never see that anymore. One single page. And here what they say, we basically say, we wish to suggest a structure for the salt of DNA. This structure has some novel features which are of significant histological or biological interest. And it goes there, one page, and the other thing is just the references that they have. What a difference. Again, now we are doing the analysis of the meta-analysis of the systematic review of the same article in 20 pages to just say it's nothing that is really important. These guys are saying this is something that we think that is important, and it gets accepted. Now you go through 20 journals, everybody rejects what you are signing, you're giving an opinion. It has to be something important, and these guys just wanted to suggest something. And it goes on Nature, and these things basically change medicine forever. Around that same time, again, talking about exciting things, it was the first kidney transplant. Again, that was at the Brigham and Women's in 1956. So it was a very exciting period, what was happening in there. 20 years later, in Nature, when it was the 100th year of the journal, they asked Dr. Francis Crick in here and say, hey, what do you think that these guys, us, are going to be doing in the 2000s with all of this information that you are providing, all of this DNA stuff? What do you think that is going to happen? And my guy, he was right on the money. So this is, again, almost 40 years ago. They asked, what do you think that we're going to be today? And he said, between now and the year 2000, this research will be on a massive scale. I'm going to show you where we are right now on that. These problems in molecular biology, at that time, they were just trying to read the DNA and stuff like that. It was huge for them. It's going to be solved. Now we can read the DNA in few hours. We can solve all of that. And he was smart enough to understand that it wasn't not going to be just the single DNA was going to relate to every single disease. He said this is going to be a lot more complicated than that, but the start is going to be with the DNA. So here's what he was mentioning is we as physicians and everybody that takes care of patients, we understand that there is all of these different conditions. For example, in this case, obesity. But when you say obesity is related to diabetes, to asthma, to insulin resistance, and there is all of these networks of multiple diseases that they are all connected, one with another. What we are understanding right now with all of these phenomena, with all of these omics, is how everything is happening at the cellular level. So we are trying to understand this a lot better. Once we understand this, we can understand how these two conditions are connected, because we are going to understand the cellular level a lot better. And then the third component is people may have the same DNA, but the social networks, the family history, how they can represent significant differences. So obviously, we can collect this information on massive scales. Again, as you can see now with Google and stuff like that, the information that we can get is incredible and is very fast. And with the information that we are getting here, we are going to understand so much better all of these network of diseases. So now going into these omics and trying to explain what this is about, this is like, again, 4 different components of this story. The first one is the epigenomics of the actual DNA. So we really are trying to understand a lot better. It's not just the genes that are here. Again, the DNA, the map is in here. It's really packed into these proteins, but you need to methylate the DNA to open and then start producing the RNA. So this area, we have made significant progress, and we can, again, read the DNA very quickly now. Then it comes the activation of all of these genes. That is what we call the transcriptomics. So in any particular event, in transplantation, rejection, infection, we can try to look and see what kind of genes are activated, because those genes are going to produce a lot of proteins. We produce more than 100,000 different kind of proteins. And what we can do now with this proteomics is trying to understand it in a single situation, all the proteins that are active or inactivated, and try to understand, again, how these correlations between all of these things go into there. And then the last part is the metabolomics. After you have a reaction with proteins, enzymes, and things like that, there's going to be some metabolites that are going to be produced, and those things can be analyzed. And when you analyze every single one, you can have a lot better understanding of this. So this is like a really representation of what omics is. In the genome, we can see what can happen. It's the instructions manual. This is all the things that we can build up with, and these are the things that can happen to you. When we go into the genes, activation and inactivation, we can see what appears to happen, what makes some part of the DNA become more active and some part become inactive. The proteins are the ones that really make things to happen. And then the metabolites, we can see when we look at the metabolites what happened. And when we understand the 4 things together, I think that this can be a significant difference in the way that we practice medicine today. Now, is this theory or is this reality? This is coming so fast that it's really hard to grasp what is happening now. So the Genome project, again, the part of genomics is completed. So we can read the DNA now very, very quickly. So all of this part of understanding the structure of genomics, we are doing excellent in there. This is the phase in where we are right now, is understanding the biology and looking into all of this, again, transcriptomics and looking at the activation of genes. Over the next, again, 15 to 20 years, it's going to be the combination of these 4 areas, all of these proteins, metabolites, activation of genes. We're going to put all of that together. And then finally, after this period of time, they think is in 2020, but maybe a little bit later than that, we're going to be able to understand every disease so much better, how they work, that we may be able to revolutionize how we take care of our patients. How fast is this happening? Look at this. This is the number of machines that are around the world. Look at here in China, 101 of these human genome machines working. Here in the US is, again, hundreds of these. And we have, again, obviously here in our school, we have some of these machines working too. It's an incredible output, or just working every day trying to obtain more information about particular diseases. And the cost of this is decreasing in a way that the first genome that was read, they think that was over $100 million, what they have to pay to read that first genome. And now you can go and probably by the price of a couple of MRIs and a CT scan, you can get the human genome read. And this is where we are right now. Can imagine, again, in 5 to 10 years, the cost of this is going to be probably less than $1,000. You can have the entire genome read for you. Now, in terms of the reality of diseases, and you can go to the Genome.gov page and just look at the history of this. So each one of these is a chromosome, and they are looking in different dots. The different colors are this cardiovascular disease, gastrointestinal disease, pulmonary conditions, obesity. Every color reflects just a group of diseases. And you see there are a few dots here in 2007. Then it goes to 2008, 2009, 2010. So it's just how much output are we getting? There is at least 100,000 patients already with coronary artery disease in this database. There is over 80,000 diabetics that they have all of these things wrong. And look where we are right now. It's incredible, the amount of information that we are getting and seeing how different conditions get combined. And this is progressing in an exponential way where we are connecting the dots of all of these diseases. Now, from the practical point of view, are we doing anything today, taking care of patients where we are applying these things already? So I'm going to give you a few examples. And obviously, some of these are related to pulmonary diseases and some to transplantation. When I was doing my fellowship and I went to one of the oncology labs in here, the research project that we were doing, and this is 15 or 16 years ago, was looking about this enzyme that is the tyrosine kinase. And this was kind of showed that was one of the main proteins that was related with the cancer progression because it was very active on all of these adenocarcinoma cells. So in patients with lung cancer, we know that this pathway that is called the epidermal growth factor receptor is extremely, extremely active. And so what we try to do is kind of come up with a medication that blocks this enzyme to see if we can take care of patients with cancer. And this medication is known like Iressa. So what we do with this medication is we block this translocation again of this information from the tyrosine kinase. We are hoping that these tumor cells are not going to be able to duplicate and the tumor will disappear with these things. So we do a clinical trial with this particular medication, and really unfortunate, again, this is the results with the placebo, this is the results with the medication, and you see that, again, it wasn't very successful. But then the power of the observation is some of the patients on the trial, they have this kind of response. They have this really advanced lung cancer. This is an adenocarcinoma, bronchoalveolar cell carcinoma that completely fill up the lungs with this. And they gave the medication, and then a few months later, the cancer almost disappeared. But the study was negative. So what do you do with this? And you can think about this. How many medical trials we have done when the final result is not that great, but everybody saw that some patients responded very well. So all of these OMICs, all of those things came to the rescue of this study. And at the Mass General Hospital, they have like 10 patients of this. And they say, you know what, let's run the DNA on these guys and try to figure it out in these cancer cells, in these patients that responded and see this anything that is different. And what they found out that there was a mutation on the EGFR receptor. And with that mutation, what it makes is that mutation, when they have that, the tyrosine kinase pathway becomes extremely active. And now what we do with these cancer patients, and we do it today, every time that we diagnose an adenocarcinoma in the lungs, we check for this mutation. And if they have that mutation, they get treated with this. And now even if the final result is not perfect, you see how different the graphic is here in terms of survival. So this is a real implication of how these things are working nowadays. This is another condition, asthma. Again, everybody with asthma get the same class of inhalers and some going high dose of steroids. And this is looking into a population of patients with asthma, same stuff. They give this IL-13 inhibitor. The results were not really significant on these patients, so the medication doesn't work. But they go back and say, you know, there were a small group of patients that they really have a good benefit of the medication. Let's do the same stuff. Let's look over these patients and see what happened. And they found out that when looking at all the activated proteins, that there was a protein here that is called periostin that was very high in some of these patients that responded. So eventually we can get the asthma patients, look at them, and try to decide you are the kind of patient that may respond to this medication, saving you to be on a high dose of steroids. That would be awesome. I mean, we could do the same thing on transplantation. And we can find out what patients require high dose of steroids, which ones don't, and how they do respond. So now obviously we are here talking about transplantation and how can this change what we do in transplantation. And here's the reason that I think that is so important. This is around the time period that I've been, again, working in transplantation as the program director here. And so we have now over 300, 350 patients that have been taken care of since I go into the institution. And everybody that comes here for the transplant is alive, obviously 100% of survival at that point, and they go through an operation. And what we are unfortunately seeing is that around 6 years, 50% of the patients, so I have over 170 patients that are already lost, that again, in less than 5 years after the transplantation. But we do have a couple, again, other patients that they just do very well. So we have here Gina and Jeff. These patients, I transplanted them, or we transplanted them here in the first year when I came here into the institution. He actually just came from St. Andrews. He was there a week ago. He was playing golf in Scotland every day. And Gina is still running marathons. And you ask me why, I have no idea. I have no idea. I have done the same for the ones who died for them. And I don't know why. And this is why I think that this area is going to be really important trying for us to answer these questions. And one of the problems that we have, in particular with lung transplantation, but applies to everything, is that we are making the diagnosis of rejection. That is the main reason why these patients die, initially with clinical basis. When we were seeing, oh, they are dropping the PFTs, they are short of breath, they may have rejection, and we diagnose them. Now we do some kind of pre-rejection biopsies. We try to schedule biopsies, even if they are doing great. Patients don't like that. You are doing fine, but you still have to come for a bronchoscopy tomorrow and see if we can pick up this rejection early. But I think that what we need to move is we need to move really early when we can have some impact, when we can determine what is going on before we wait for the clinical findings, while we wait for the pathological findings. We really need to find these molecular aspects and see what is happening there. So why do I think that omics will offer to transplantation? So I think that when we're having the pre-admission assessment, when the patient is coming for transplantation, we can establish in the recipient and also hopefully in the donor, and we can do this very quickly, the genetic risk. They say, this is a patient who is made for transplantation. I'm sure that Jeff and Gina and many other patients that you have, they have something different that make them so special, that never rejected, never have a problem. And we can look into the DNA of all of these patients and try to figure out what is the risk. Not that we cannot do the transplant, but how we can modulate the medications. We currently look again into the antibodies and donors and all of that stuff. Then the operation happens and we do the transplant, and after that, again, we can look into this, knowing the risk of the patient and say, this patient needs to have induction therapy versus no induction therapy. Are these some that may benefit from bone marrow transplantation? What kind of medications we need to use for them? Once the transplant is done, instead of waiting for the clinical findings, instead of waiting for the pathology, we can look into all of these biomarkers, gene expression, doing all of those things. When they come here and they have a blood test, for the kidney transplant, they may have a urine sample. For us, maybe a BAL or just a sputum sample that can give us a lot of information on what's happening on those patients, trying to identify early what's happening with them to determine if they are going into the group that has good tolerance versus the group that is developing more problems with their rejection. With the final goal that we're going to determine if they have tolerance or these are the patients that really they are not tolerating the organs very well. So is there anything happening in transplantation with this? I'm not an expert, obviously, in the area of kidney transplantation and follow-up, but this is from the New England Journal in July of last year. And basically what they are doing is looking into the second area of this omics that I was looking is the gene activation. And they were looking samples of kidney transplant patients, and they were looking into different areas before, again, from the time of the transplantation until they develop rejection. And they were looking at molecular signatures, and they run the entire thing, and they found that this activation of these 3 genes is associated when the genes start being more present. These patients, they have more rejection. When they are inactivated, they don't have rejection. And if you actually induce the patient or give thymoglobulin, you suppress those genes. So again, obviously, this is not a standard of care right now, but it's showing how eventually we can get to the point that it's not the kidney biopsy, it's just the activation and molecular map of these patients, or the activation of genes that can tell you, okay, this patient is a high risk or no risk or rejection. Same thing with heart transplantation. This is, again, a gene expression study following, and it's a randomized clinical trial. When they have, again, a lot of patients that have heart transplantation and they randomize one group to have a cardiac cath with biopsy versus our group when they look into the same thing, gene activation, and see what genes are active, and see if we can predict the risk of rejection or not. And if you see the two graphs in here, it was exactly the same. So with a molecular level, they were able to prevent doing cardiac biopsies on these patients to diagnose, again, when the patient has a high risk of developing rejection. So what are we doing here in our institution? We are very lucky, again, to have at the VA now, Dr. Ahuya and his team, that they have a center of personalized medicine, and they have one of these human genome machines where they are running, again, multiple studies all the time. And he approached me like a couple of years ago and said, hey, Luis, you want to look into some of the issues with transplantation and try to learn a little bit about this and see if it's important. So this is, again, the unit that he has there at the VA hospital that produces all of these things extremely quickly. And what we are doing is looking at a population, is around 35 of our lung transplant patients. And while we are looking at them, we are looking at the recipient and doing all of these genomic studies while they are waiting for transplantation. We repeated the day that they come here for the transplant, and we get also a sample for the donor. We repeat this at day 1, day 7, 1, 2, 3, and 4 months. And then if we do biopsies at 12 months, we repeat this. So what we are trying to find out is what happens when we do a lung transplant during this period of time, what gets activated, deactivated. Again, I have no idea what we're going to see, but this is the beautiful thing about this. Before, you have to be this super smart guy that say, oh, this is the gene, this is the tyrosine kinase that becomes really activated. Here, you don't need to know that. You just run everything, you figure out what it is, generate that hypothesis when you see what it is. But it's not like you have to really predict what's happening. You just run the whole thing and see what happens with these patients. So we have a population here of 25 of our lung transplant recipients that went through all of this, and we are just finishing the collection on the last few patients on this. We have, again, what we call the elite group. We have already 14 patients who are like Jeff and Gina, patients that never have issues. And we run, again, all the tests on those patients. So we're going to look the best patients and see how they look. We are looking what happened actively into these patients, and we have a control group, is patients who don't have transplantation. And we are hopefully going to be able to find some differences into these patients that will help us to understand that a little bit better. The goal is eventually that something like this is like a patient comes to clinic, and instead of relying 100% on a chest X-ray, PFTs, or something like that, you're going to have a map that is going to show you this patient is in a group where it looks green, everything looks nice, cool, there doesn't seem to be too much activation of things. This patient may have a lower risk of rejection. We can lower the steroids, we can keep the prograph a little bit lower, we can save those kidneys from going in, again, renal failure. Or this is a guy that is looking like everything is going more towards rejection, we have to be more aggressive and stuff like that. So that's why, again, I'm hoping that eventually we can provide to our patients with all of this. So in conclusion, I think that medicine needs to continue very exciting, not just for our patients, and not just for us as physicians or people taking care of them, but just for everybody. This is an area that has to come a significant excitement to everybody. I know that today we do the best care that we can, but I think that we are at the end of this era of medicine. I think that we need to move into something new, and many people think that that area that is going to keep up into the headlines and making all of these changes is going to be all of this omics stuff. So with that, when I finish my presentation, and if you have any questions, we're happy to take them. Thank you.
So really interesting, great perspective over the kind of history of medicine. And I was struck by your curve as it went up and then came back down, and couldn't help but think about, over the past 5 years or so, how there's been a significant reduction in funding for medical research, and whether that's impacting this to some degree, and whether that will impact our ability to make discoveries going forward. And I just don't know if you had a comment on that.
I was actually hearing on NPR, and probably many of you guys heard this last week, about like and Dr. Sigara probably have a better perspective than anybody because he's the president of this, or the chancellor of this huge institution. Is apparently there is more labs now in in all the universities that has ever been in the past. So we are set up to doing all of this kind of research and find and do a lot more than we ever done before. But the quote that they have is almost 50% of the labs are underused or not used nowadays because exactly what you are saying. The decrease on funding and people going into science and living science because, again, how difficult it is to get the resources anymore. And the comment that there was that was very interesting, I'm not saying this is my idea, but it kind of came to me like really important. The things that I show you, this Watson and Crick stuff, when people was able to think with something that was completely revolutionary and get funding for that, that's gone. Everybody, when they apply to the NIH, they go back with the grant, with the idea that is already proved, that works, and you go and you see, again, some of the physicians here in our institution, you see people with 30 years of continuous grant, and you see that the grant that they have today is very similar to the one that they had 25 years ago, spinning around the same idea, because they are playing safe. The funding is so limited that they don't want to do a lot of funding for risky stuff that is going to revolutionize and change everything. So I agree with you. I think that that's the way I feel, and I don't want to be pessimistic about this. Again, especially these young students here, and I don't think that we have ever been able to provide the care that we do today. And it's very exciting what we can do for our patients. But this excitement that I try to show that happened, again, that my dad saw with his 50 years of practice, I'm not seeing that anymore in the medicine and practice. I'm doing the same thing, and something new needs to come. And it's only research and funding at a huge scale what's going to be able to revolutionize this. So I agree with you 100% on that. I don't know, Dr. Sigara, again, you have been too much into this area with funding and huge.
Yeah, I mean,
no,
it is a significant problem. You know, even 15 years ago, 20 years ago, the chance of getting an R01 was in the 20-25% range, and now it's down to 7%. I think we are fortunate at UT System, but it's still going to require game-changing policy decisions in the sense that we get a lot of money from oil and gas, and that's going higher and higher. The problem is that you can only use that for bricks and mortar, not, except for UT, honestly, not real people. But for the first time, we broke ice just a month and a half ago, which we developed a neurosciences initiative, where actually now that Reach to be able to provide about $20 million in grants to be able to do high-impact research, to get seed funding for that, so that you can draw down federal funds from the Obama Brain Initiative. So I think even the governing boards and universities need to kind of change their mindset. I think the second aspect is that we, as faculty and administrators in our universities, have to really understand that we have to encourage our faculty to also partner with industry. And because, that money is also pretty good. It's expendable. You can spend it just the way you can a grant. But we've got to have different partners, a partner in the federal government to get this work done. Once it's real. I've got a question for you. First of all, I agree with Ken. Fabulous talk. Gave me goosebumps, and I know I made the right decision to come back. Second is, with all this data, right? I mean, we're going to be capturing,
terabytes.
Terabytes of data. What is your view about the need for high-performance computing, which is still right now far more expensive than your sequencing?
Yes.
And in order for UT to be able to kind of advance in this game-changing way of where medicine is going, do you feel we've got adequate high-performance computing or not?
That's going to be one of the areas that we really need to make significant improvement, but it's going so fast. The areas, again, that we are going, and I agree with you again, is when we are talking that the data that we have right now is in 100,000 patients with coronary artery disease, in 60,000 diabetics, we are not going to find the answer on those. We're going to have the answer when millions of patients with these conditions can get this information and put it into supercomputers and do this very, very quickly. I don't know the answer of how fast is that going, but I think that it's coming fast enough to the point that, just think about this, you get in your iPhone, you go into Google Maps, and you start writing the number, 7703F, and then you start seeing, you can be anywhere in the world, and you start seeing this address with 5 numbers. This is gonna be the same thing with the DNA. Again, it's just few codes, few letters on the DNA are gonna just give you a signature. So supercomputer, obviously, that's one that you know the answer better because you have been on, again, in UT, and they have supercomputers, really good computers on the research labs in there. It's gonna be one of the limiting factors, but it's coming so fast too. Again, just look into today, we have this company from China, Alibaba, coming for millions of dollars in the stock market. It's happening everywhere at speeds that is just incredible. So I think that this is gonna be moving along. I don't personally think that computer is gonna be the limiting factor down the road because, again, how fast the things are moving on that aspect too. Again, the things that we can do now with our computer in our pockets is just incredible, and hopefully will not be the major limiting factor, but definitely it's gonna be terabytes of information coming and analyzing all of this data. But I think that that's what, again, going back into transplantation will be extremely exciting. The thing that kills me when I'm doing an evaluation for transplantation, and I tell this to the patients and say, we do the same. And all I can promise you is that we are very committed in this program, that we're gonna work really hard to make this work. We have a great surgical team like you guys are in your programs too, when I don't think that that's the major aspect of transplantation anymore. We can provide them the best operation, the best care, but I cannot tell you, I have no idea how are you gonna do. And once I do the transplant, we are always reacting to problems, but we cannot be proactive. And my hope is that before I retire from here, I can just answer that question to the patients and just try to tell them, yes, I think that you're gonna do very well. I think that you have high risk, but we still will do it, and we can use this medication because of your risk. And I'm hoping that this is gonna give that answer to us and to our patients. And because I don't see any other way. I don't see any other way unless that this gets there. I think that I will retire doing the same 20 years later.
So Luis, we're doing a trial at MD Anderson, oncology expert advisor. It's a partnership between MD Anderson, IBM, and IBM Watson for cognitive computing for all
Yeah.
this data, to help the physician at the bedside to be able to do the best personalized therapy, and it all comes in your Apple
Yeah.
or in your iPhone.
Yeah.
We don't know how it's going to work out, but
That's,
in the next 5 years, we'll have good data.
yeah. I think, and again, it's not you have the director of the NIH saying that this is the way it's gonna go, this is the way that he's gonna assign the money for resources. So this is, again, it's coming, what is interesting and looking into this is, still I don't know much about that. The good thing, I don't need to know a lot. I need to provide the patients, I need to ask the right questions. These people and these machines are gonna give the answers, and that's what is the beautiful thing about this, is you are not depending on somebody really smart in a lab to come with this idea and say, this is the protein or the enzyme that generates rejection. Those guys, again, this is not gonna be the answer there. You run everything, and then when you look into all of this data, and everything is computed, it's gonna give you something that you generate the hypothesis from there. So it's not a priori hypothesis, it's actually after the data you generate the hypothesis, and I think that that's gonna be the real revolution on that. And what to me is more exciting when I have the picture there with, again, my father, myself, and the next generation, those are my daughters. If one of them pick medicine, or anybody of you guys that are young here doing medicine, it's gonna be something great that is coming to you, and again, that you're gonna be as proud as I was showing before here, something that's gonna say, oh yeah, the medicine that they used to practice, and Dr. Angel and those guys, it's really all thing, this is the newest stuff, and it's really exciting. Now every patient that comes here, we can provide a really personalized care, and we can decide what to do better. We can develop medications in a different way, because again, we are, in my view, just in a tough period in which we do the best medical care that we have ever done, but it's not much different than we have done 15 years ago. At least that's the way I feel in what we are practicing.
So, thinking back to when I was a resident in the 80s, early 90s, we practiced medicine a little different than we do now, but not a lot. But I think, looking back, we responded to a lot of events, as opposed to now we've done, I think, outcomes analysis has become so good now. We can look back at the way things have been done and we learn from that in a very thoughtful, strategic way. Instead of saying, well, in my experience, which I don't think is very valuable, we can look at huge data sets and say, you know, of all these patients, this is what happens, and this is the best standard of care. These are the events that trigger something to preemptively look at an event as a sentinel event. And so we went from reacting to events to being able to anticipate them, and now being, and what you're talking about is being proactive to even before the event happens. So I kind of see this transformation at this period as being able to intervene into an event before we even see it clinically. So I think it's a really interesting transformation, and I hope I beat your survival odds so I can be alive to see it happen.
All right. Pam, how do you see this from the pharmacy point of view?
Personalized cocktail and biologics.
Yeah.
Well, when are you going to get your preliminary data?
So we are, again, the group that we call the elite, we have just one more sample to get because they run all of the samples at the same time. So we have 12 of the 13 patients, the samples are there. The follow-up bronchoscopies, they are the 20 patients that we already, or the 25 that we have, they are running those analyses right now. Our clinical part is, for me, we need to have a database of every point that we have a sample, how the patients did and everything like that. So while I'm finalizing that part, we hopefully will get together over the next 2 or 3 months and look all of those things. And this is what I'm hoping that is beautiful. Again, this lung cancer management was changed because of 10 patients. Again, 10 patients that they find out that there was something different about those groups. So again, I don't want to be naive and think that these 10 patients or these 13 patients in transplantation are going to give the answer to this. But even if we suffer with lung transplantation more than you guys because of all of the bad events that we have, at the same time give us the opportunity to understand this better because it's more frequent and we have to biopsy and follow these patients with a lot more procedures than any other transplant. So we'll see. Again, and Dr. Ahuya and Wei-Jin Ha, who is the faculty who is doing the research, they are really smart and they will probably come up with some good ideas of what's going on. Our plan is, again, probably in the next 3 months have all of this data, and for sure we will come back and share the data there that we obtain, but then just try to go into a bigger grant when we just go into different transplants or different institutions to start looking larger populations to understand a little bit better what's going on. I'm very excited, and this is what, again, I mentioned is so nice. I have no idea what is coming up, and I don't need to know exactly what's coming up. That's why it's nice. I just have to provide the right thing, the right patients. And when you mention all of this about outcomes and stuff like that, that's our role, trying to be able to look at populations with similar characteristics the best way that we can. Because these guys who do these omics, they are sitting there in labs. It's very hard for them. And it's not like you can run everybody who's in this room, go there and run these things because he's not going to get any data. We have to isolate different groups of people and say, this group has these characteristics, these ones, let's look what is common on these ones, and then we go from there. So thus, we have a significant role as clinicians into this, having, again, understanding these patients very well, and then go from there. All right, thank you.